Welcome back to my YouTube channel. In this video, we will look at the treatment of Morton's neuroma, a fairly common problem that can cause significant pain in the feet. Each of us has nerves, called interdigital nerves, that run between the metatarsal bones of the foot, which you can see represented in yellow in this model. Sometimes one or more of these interdigital nerves can become enlarged, ranging from a few millimeters to over a centimeter in diameter. This enlargement of the nerve generally occurs just before the nerve itself divides into two smaller nerves that run towards the toes. The cause of neuroma formation is not yet fully understood, but it appears to be a chronic irritant, such as a mechanical overload that causes fibrous scar tissue to grow around the nerve itself. It is interesting to note that reduced elasticity of the calf muscles may play a role in the development of this chronic irritation, causing the foot to be overloaded during the push phase of the step. The symptoms of Morton's neuroma usually affect the third intermetatarsal space of the foot, as shown in this photograph, with pain. Occasional electric shock, like sensations radiating to the corresponding toes, which may also feel numb, but it is not uncommon to also experience sensation of a pebble in the shoe or itchy sensation of a rolled-up sock. Many patients complain of pain so severe that they have to take off their shoes to massage their feet. As for the diagnosis of Morton's neuroma, I always recommend performing an X-ray while standing and not on the X-ray bed to assess whether there are any bone problems that may coexist with Morton's neuroma. Magnetic resonance imaging, MRI, plays a key role in diagnosis and is therefore the test of choice if we suspect this problem, while ultrasound is much less accurate and therefore less useful for diagnosis. For this reason, I believe that ultrasound should never be prescribed, but for the same reason, I do not request a CT scan either. There are several treatment options. In the early stages, it is reasonable to try conservative treatment, which may include physical therapy and orthotics, which I often find not very useful, however. Local injections of cortisone, alcohol, or platelet-rich plasma, PRP, may also be considered, as well as radiofrequency therapy. Surgery is only considered as a last resort. As I mentioned earlier, Morton's neuroma is frequently associated with short calf muscles, so it is advisable to start regular, specific stretching exercises right away, as shown on my YouTube channel or website. We have said that it is possible to perform infiltrations that can be of cortisone, which is injected in minimal quantities at the nerve level, but it is also possible to use the so-called platelet concentrate, also called PRP, which is the plasma obtained from high-speed centrifugation of a vial of your blood, which at this point becomes rich in growth factors. It is also possible to use a type of alcohol mixture with local anesthetic to be injected under ultrasound guidance at the neuroma site, with the aim of burning the neuroma cells themselves. Then there are the radio frequencies, which are waves generated by a special needle that burns the neuroma cells. Radiofrequency treatment can be performed by an orthopedic surgeon or a radiologist. The results of complications described in medical literature for injections and surgery, we can clearly see that surgery has a significantly higher complication rate than injections, which, however, have a much higher failure rate than surgery. It is interesting to note, however, that negative results in terms of complications from operations particularly involve surgical procedures performed using the classic technique, which means cutting the skin a few centimeters and cutting the nerve immediately above and immediately below the neuroma, which is then completely removed. In addition to the possible complication of skin damage, there is a well-documented complication in the area where the cut nerve can form a new neuroma, shown here in red, which is potentially even more painful than the one we initially removed, and which, in some cases, must be treated surgically with a more complicated procedure than the original one. For this reason, I have chosen to adopt, when possible, the minimally invasive technique that involves simple decompression of the neuroma, cutting only the ligament above it and thus reducing the pressure it exerts on the neuroma when we walk. In this procedure, the nerve is not cut at all, and the neuroma remains where it was before the operation. Only in cases of persistent pain will a new surgical procedure be considered using the classic technique to remove the neuroma as described before. The probability of this happening is around 5–10%. The risk of failure increases significantly if the minimally invasive technique is used for neuromas larger than 10 millimeters in diameter. So in this case, I prefer to use the classic technique from the outset. As you can see in this video, the minimally invasive procedure involves 2 small incisions in the skin, one on the back of the foot, where a retractor is placed to stretch the ligament that we are going to cut, and another small incision between the 2 toes, through which we insert a guide tube containing a fiber optic camera with a diameter of less than 3 millimeters, allowing us to see the ligament to be cut. In this sequence, the camera focuses on the ligament, which is the white structure you see at the top, and which we are going to cut with a scalpel. Regardless of the type of surgical technique, the recommended anesthesia is peripheral, specifically in the calf, where ultrasound is used to identify the nerve to be numbed, injecting a small amount of local anesthetic. This type of anesthesia is extremely effective, even for managing post-operative pain, which is reduced to a minimum. After the operation, you can immediately put your weight on the ground using a shoe with a flat, rigid sole, such as the one shown, which you will need to wear for the first 2 weeks to allow the small surgical wounds to heal. During these first 2 weeks, it is best not to shower to prevent the wounds from getting wet with water, thus risking infection. It is also advisable to avoid driving a car or motorcycle for the same period of time. Physiotherapy is not always necessary unless there is post-operative swelling and pain, which is rare. Obviously, there are risks and possible complications, even if they are unlikely. In addition to the risk of no improvement in painful symptoms and therefore the need for another operation, but this time with a longer incision to remove the neuroma, there is the risk of infection, failure of the surgical wounds to heal, and the need to wait several weeks for the residual swelling to improve. To discuss the risks and complications of surgery in more detail, I recommend that you talk to your surgeon, whom you can always trust. Thank you for your attention and for subscribing to my YouTube channel.